Good morning. Thank you all so much for being here today. I'm Senator Carri Hicks. I represent Senate District 40 in the heart of Northwest Oklahoma City. Today, we are convening to talk about a very critical concept in trying to modernize and update our state statutes to really reflect innovations and modernization of science surrounding HIV. I'm so honored to be joined by my colleague who will be this is a joint study from Team Senate SIS. And so we are joined by some incredible experts to lend their voice to this conversation and really help us glean a better understanding and a deeper connection on ways in which we can really move our state forward in addressing some of the concerns. Senator Kirt.
Good morning. Thanks again for being here. I'm Senator Julia Kirt. Getting to have a public forum, whether or not it's part of the official agenda, I think is worthwhile. And I think we've seen not only proactive steps by Freedom Oklahoma and others to bring us into the modern era and reduce stigma, but also last year we defended against some legislation that would have been really hazardous for public health. And I saw a lot of concern raised about increased criminalization of STIs and that we really need to revisit and talk about the importance of public health response. And I think this study connects with that bigger conversation that's happening. And I think for us to be proactive is very important this year. And I'm not taking for granted that any of our colleagues understand the importance of a public health approach or how that's different from a tough mindset of the past where criminalization was viewed as a reasonable response to what needs to be a public health approach. So I'm really pleased to get to be a part of this. Thank you to Freedom Oklahoma and others who have been leaders in this area. And please, we're looking forward to learning. We're thrilled to listen and hear from you. And I hope that we can have a real conversation on an ongoing basis. And I hope we can share information with other legislators and get them in that conversation as well. Because I think we just can't assume, especially the last few years, I think it's very clear that we can't assume people's understanding about our well-being and our group well-being in our communities. So thank you again for being here.
Sure. So just a couple of housekeeping items for our presenters for today. If you will approach the podium as we call you forward, you'll just use the button that has a person to turn your microphone on. And then if you'll turn that off when you finish speaking, that will help us move the flow along. Obviously, we'll want to make sure that we have plenty of time for questions. And so we will get started with our very first group. This is titled HIV 101, What HIV Is and Big Picture Myth Busting. And I'm so honored to be able to welcome these folks from Tulsa with the HOPE organization. Jeff and Jeremy, thank you all so much for joining us today.
Thank you. Thank you for having us. Senators, we appreciate everyone being here today and the opportunity to speak on HIV/AIDS education, specifically here in Oklahoma. I'm Jeff Burge. I'm the Development and Communications Director at HOPE in Tulsa. This is my colleague, Jeremy Simmons.
I'm one of the founders, and I'm currently the Director of Training and Volunteer Services.
So we appreciate y'all having us here today. Thank you
very much.
All right, and if you want to learn anything about HOPE, there's our QR code, but we're happy to share this presentation with you for anyone that wants to see it after this. So what is HIV and AIDS? HIV, otherwise known as human immunodeficiency virus. HIV is the virus that caused AIDS. A person with the virus is HIV positive. AIDS, acquired immunodeficiency syndrome. AIDS is not a virus, but a condition. HIV plus does not mean the person has AIDS. Another important part here is U equals undetectable, which equals untransmittable. That's really important that people understand that terminology there within learning about AIDS. I'm going to hand it over to the timeline here to Jeremy. He's got a lot more knowledge on this, so he has a few more anecdotes that he wants to put in.
Sure. Just to kind of give a general history, it was in the early 80s, around 81, when people started getting sick, and we realized there was a problem, and especially in the United States, it was affecting gay men more heavily, but we could just tell there was a sickness. And then in 84, we identified that it was a virus and named it HIV. And here in 85, antibody testing was developed, so that became an accurate way to let people know if they had the infection. And in 87, Oklahoma mandated HIV and AIDS education in the state, which was actually kind of progressive. It was a pretty quick response for Oklahoma. Some of the details about the education are a little broad and a little vague, so we can definitely improve that a little bit over time. And also in the late 80s, we had the first antiretroviral drugs developed, which was a big turning point. So you can see between 81 and 87, we realized there was a problem. It hit us later. So worldwide, it was a much larger problem before we could even test for it, much less develop some of the beginnings of medications that were successful. In 89, AIDS cases reached 100,000 people in the United States. So again, sometimes too, we talk about this as a more recent infection. And for the United States, that's maybe not a large number, but 100,000 people had it in the late 80s. So it was been here for a long time. And 92, that's when rapid HIV testing developed. I don't have a slide for it, but I wanted to continue a little bit on. As we move into the late 90s and early 2000s, we got to be a more modernized approach where we kind of are right now. And that's when we developed better antiretroviral drugs. So there became a lot better medication so people could actually live with this and manage it realistically. And also more rapid testing services became available. In the late 90s, in the mid 90s, there was also a big push for states to have at least some limited anonymous testing sites. So agencies like Hope and Tulsa were selected as limited sort of pilot programs that could do testing without taking any names or any too much specific information. That was a big key in testing, especially in this part of the country, so people could realistically access services without worrying about repercussions, particularly as the state passed criminalization laws against HIV. So it was around 2012 that anonymous testing got phased out of Oklahoma. So for a while now, we haven't had that option. So that does deter some people from accessing as frequent testing as they normally would. And then more importantly, later on, it was much more recently, we figured out as medication got better and better, that undetectable equals untransmittable. So not only can people live a very long time with HIV and feel well, but they're not at risk for accidentally transmitting it on.
Some national statistics here. The total number of HIV infected persons in the United States is estimated to be over 1.2 million people. As of 2021, there were 36,136 new HIV diagnoses. People aged 13 to 34 account for 58% of new HIV infections. So obviously that statistic is alarming that younger people who have more knowledge are still acquiring it. Oklahoma statistics, there were 387 newly identified cases of HIV in 2021. 21.7% of these new cases were between the ages of 13 and 34. So you see that again. There are currently 6,948 people living with HIV/AIDS in Oklahoma. We are one of 7 states with a rural burden of HIV. So we also need to identify that. Transmission, I'm gonna hand over to Jeremy again.
Body fluids, there's a long list of possible body fluids. The main things that we need to focus on when it comes to realistic transmission are blood, and that's male or female sexual fluids, including semen, preseminal fluid, and vaginal fluids, and breast milk. One of those things has to get into a mucous membrane, so there's a long list here, or a cut or a tear in the body. The main activities, though, so when we're talking about the fluids and the transmission routes, we can get a little distracted because it's overwhelmingly in the United States transmitted from unprotected sex. Secondly, from sharing infected needles or from mother to child.
Some symptoms of HIV within 2 to 4 weeks, about 2/3 of people will have a flu-like illness. This is the body's natural response to an HIV infection. Flu-like symptoms can include fever, chills, rash, night sweats, muscle aches, sore throat, fatigue, swollen lymph nodes. Symptoms can last days to weeks, but not everyone will get these symptoms. The only way to know you have HIV is to get tested. Some facts, by age 25, half of all sexually active people in the United States will have contracted an STI. The Center for Disease Control and Prevention estimates that nearly 20 million new STIs occur every year in this country, half of those among young people aged 15 to 24. Just like HIV, you cannot tell if anyone has an STI by relying on symptoms. The most common symptom of an STI is no symptom at all. STIs which cause sores create an open doorway for HIV to enter the body. Birth control pills will not protect you from HIV or STIs. So prevention is the key. For every $1, and this is Hope's statistics, but every $1 Hope spends on prevention, we save the community $5 in directed medical costs per year. The average lifetime, and this is discounted medical costs to treat HIV, is $420,000 per person. A case, this is just, the prevention is key. A case of 1,000 condoms costs around $100. An HIV self-test is around $50, or a test at a clinic is around $30 to $50. Both of those are free at Hope. But it's just showing again that prevention is the key. We have to be forward thinking about HIV/AIDS. Some references here where we got our statistics and resources that we use within our community. And we are, thank you for allowing us this time. We're open to any questions you may have for us.
Perfect. Thank you so much. When you're talking about the rural burden, could you maybe expand upon that just a little bit?
Sure. So I don't have the 7 top that has the heaviest burden of rural. So in counties outside of the metro area, right? Which Oklahoma has a lot of, we'd say probably like around 72 of the counties are more rural or suburban. So, and the CDC has identified that more transmission is happening. I don't want to get too far off topic, but also with Hep C. So we see both of these things happening in rural counties in Oklahoma. There's high rates, much higher than other states. So, and we pair up with some other states in the South and near South for this. So it's kind of some of the main reasons you would expect in some of these larger states where people have to drive a lot farther, to get into an urban hub for services. So like we talked about, Hope has all these great services, and we drive the van out to rural counties, and we partner with groups to get out of the city as much as we can, but it's still difficult to do, right? So many people just can't get in regularly, or they don't feel comfortable accessing care, because in a lot of these smaller communities, I'm from a small town, many of you have at least probably spent time in small town Oklahoma, everybody knows everybody. So there's the fear of, even if there is a county health department doing services, people just don't access care very regularly.
Thank you. One of the things during my time chairing the diabetes caucus that we've discovered is that we have a network of FQHCs across the state of Oklahoma, federally qualified health centers that are basically within a 15-minute drive of anywhere within the state. What, if any, is the response from FQHCs in helping folks access resources?
So that's a great question. So there are agencies in the Tulsa area, like Community Health Connection in Morton, that get federal funds, and they're qualified as the FQHCs. Morton, I know, has a clinic in Nowata. So I know that there are some places that have footholds in smaller communities, or at least on the edges of the suburbs that are more accessible. They don't see high testing numbers for these services. So they may be available, but I think people look at them as more basic core healthcare or urgent care in the lack of, a hospital being in the area. I think that's how they're usually used. They would have better detailed information. I just know that we often go to these same communities and we see a lot of people who haven't tested in several years for any STIs. So I don't know why but I don't know if they don't offer some of the sexual health services as much in the rural communities. I would imagine, though, it's more of like with the county health departments, because many of them still do offer STI services, at least to a limited degree. You just don't get a high number of turnout, particularly among marginalized groups and younger people.
Also, the stigma surrounding your sexual health in these small towns, you just don't want to go to your doctor and talk about that. So.
Well, perfect. Thank you so much.
Thank you for having us.
Hopefully you guys will stick around if we have some more questions throughout the presentation. I so appreciate you all. We're now going to recognize our second presentation. Okay. We are so grateful to be able, through the power of technology, to be able to bring our next speakers, Nathan Cisneros, and I apologize if I've mispronounced that, from the Williams Institute data on Oklahoma's use of criminalization statutes. And we are looking forward to this presentation. So Nathan, please feel free to unmute yourself, and the floor is yours.
I'd actually like to turn it over to my colleague, Sean, at the Center for HIV Law and Policy. First, he'll give us the legal and legislative background, and then I'm happy to talk about the data. I apologize.
Hi, all. Sean McCormick here. Are you able to pull up the slides that I sent over?
They are live. Go for it.
Okay. Maybe they're after Nathan's presentation?
Give us just 1 second. We're going to make sure we've got the right.
Perfect. There, I see them. Thank you.
Yes. And I did want to make those of you aware that we are recording this presentation. We were unable to stream it live, but it is being recorded, and we will upload it at a future time to make sure that folks are able to get this information. So thank you all so much for bearing with us on our technical issues. Sean, the floor is yours.
Thank you very much. Really appreciate the opportunity to speak about this important issue. This is an issue across the United States, but especially in Oklahoma. So I'm going to take this opportunity to first introduce some of the legal landscape before we talk about some of the enforcement data that Nathan has compiled with the Williams Institute. Again, my name is Sean McCormick, he, him. I'm a staff attorney with the Center for HIV Law and Policy, CHLP. Next slide, please. And CHLP is a multiracial organization that uses a queer Black feminist lens to analyze the issues of discrimination, oppression, and criminalization of people living with HIV and other stigmatized conditions. HIV criminalization is a facet of the broader oppression of people living with HIV and people deeply affected by HIV, especially people with intersecting marginalized identities, such as Black people, LGBTQ folks, Indigenous folks, working class folks, and people who use drugs or engage in sex work. We envision a future where folks are free from state violence, where people are not dehumanized and punished for their real or perceived health status, and where health conditions are not met with criminalization and surveillance, but rather resources and support for people to thrive. Next slide, please. As I mentioned, I'm going to level set about the definition of HIV criminalization before we dive more into the legal specifics, just so folks are aware of our understanding of the issue. HIV criminalization refers to laws, policies, and practices that impose heightened criminal penalties on people living with HIV for conduct that is not criminalized or criminalized less severely for people who are not living with an HIV diagnosis. These increased penalties could manifest in distinct criminal offenses, which we'll talk about, such as exposure or transmission laws, felony enhancements that increase the length of incarceration or fines, forced testing or treatment, or other severe penalties such as registration on the sex offense registry. HIV criminalization could also occur through general criminal laws, which I'll briefly talk about, such as aggravated assault. These laws don't specifically mention HIV or other communicable diseases, but they do, through the case law, apply to the behaviors of people living with HIV or other stigmatized conditions. HIV criminalization is a product of inaccurate and stigmatized views based in homophobia, white supremacy, and misogyny. These laws emerged from and perpetuate these prejudiced ideals. And we know from enforcement data from the Williams Institute, and we'll hear more about Oklahoma specifically, that these laws especially affect people with intersecting marginalized identities, such as transgender folks and cisgender Black women and Black women engaging in sex work. And I especially want to remember this on Transgender Day of Remembrance, that state violence is a violence against trans people and two-spirit folks. So HIV criminalization is yet another example of that. It's, of course, a national problem. 41 states have either HIV-specific offenses or enhancements for HIV-specific laws. Oklahoma has an HIV-specific exposure offense, an HIV-specific sex work enhancement, and 2 communicable disease exposure statutes. Next slide, please. I'll start with the exposure offense. Oklahoma is one of 32 states with this type of offense. In Oklahoma, it is a felony, punishable by up to 5 years in prison for a person who is aware of their positive status to engage in, quote, conduct that is, quote, reasonably likely to result in the transfer of certain body fluids onto another person with, quote, intent to infect another, and the other person didn't consent to the transfer or didn't know about the person's positive HIV status. Next slide. I'll point out a couple things or several notable aspects that are within Oklahoma's HIV-specific exposure law. More accurate, probably are lacking from the law. First, it criminalizes mere exposure, not transmission. That is, people living with HIV may be incarcerated and sentenced to 5 years in prison, despite not transmitting HIV to any person. Second, while the statute requires a, quote, intent to infect another, courts have interpreted this intent broadly. Prosecutions have resulted in convictions even when there was no clear indication that the person actually intended to transmit HIV, but rather they just merely did not disclose their status. I'll talk about the problem with disclosure in a minute. And we know that in many of these cases, the person was merely engaging in sex. And of course, that does not prove an intent to transmit HIV alone. Third, the statute criminalizes behaviors that pose absolutely no risk of transmission. People living with HIV have been prosecuted under Oklahoma's criminal exposure law for spitting and biting, despite the CDC concluding that spitting and biting pose a, quote, negligible risk of HIV transmission. We did already talk about transmission risk, but these behaviors are, many of the behaviors that have been criminalized pose absolutely no risk or a very low risk. Moreover, the statute is silent on whether a person living with HIV would still face prosecution if they engage in means to prevent transmission. For instance, if someone is undetectable, is on treatment, there is no way that they could transmit HIV to another person, but the statute is silent totally on this reality. Fourth, disclosure is also a required element, but it's often very difficult to prove. For example, a man in Oklahoma was charged with knowingly exposing his girlfriend to HIV. She alleged that she did not know about the man's status during their relationship. It was not until 6 months later that eyewitness testimony proved that, in fact, the woman was aware of the person's status before initiating their sexual relationship. Next slide, please. The second offense that I want to highlight is the HIV-specific sex work enhancement. Oklahoma is one of 10 states with an offense targeting people living with HIV and engaging in sex work. The law criminalizes people who are aware of their positive status and engage in, quote, prostitution. Convictions can result in a term of imprisonment of 5 years. Next slide, please. This sex work enhancement is missing several significant features. Again, the statute imposes a lengthy prison sentence for mere exposure to not transmission of HIV. Moreover, it criminalizes behaviors that pose absolutely no risk of transmission. This comes from the definition of prostitution, with prostitution defined so broadly. People may be criminalized for engaging in oral sex, which poses a low risk of transmission, or merely communicating with people. That is, the prosecution definition includes, quote, making an appointment or engaging for sexual intercourse. That is, people could be prosecuted under this law for merely sending messages online. Lastly, the statute does not include any intent element. There is no additional requirement for intentionality. So people without any intent to cause harm may be prosecuted and convicted under the law. And in general, this law operates very simply. The only difference between prostitution and this HIV specific enhancement is that the person is aware of their HIV status. And we've seen that the U.S. Department of Justice has found that similar statutes, specifically in Tennessee, violate the Americans with Disabilities Act by subjecting people living with HIV, which is a qualifying condition, to higher criminal penalties simply because of their disability status, their positive HIV status. Next slide, please. The final offenses or legal components that I'll highlight is some other communicable disease related statutes. I want to first identify that people may be prosecuted under general criminal laws, as I mentioned, such as assault or reckless endangerment. These laws do not specifically mention HIV or other communicable diseases, but case law has interpreted the behavior of people living with HIV as falling under these laws. Moreover, it is a felony punishable by 2 to 5 years imprisonment for a person with syphilis, gonorrhea, or smallpox to intentionally or recklessly spread disease, quote, spread disease to others. This statute provides no guidance on what it means to spread these conditions. Moreover, the definition of recklessness is totally unclear. Disclosure of one's status does not appear to be a defense on the face of the statute. And despite these problems with the law, as Senator Kirt mentioned, in the recent session, we saw a push to expand the number of conditions that are criminalized under this statute in particular. So it's very dangerous and alarming that this statute has been coming up. I want to also point out that there's another statute that criminalizes people living with, quote, any contagious disease who willfully expose themselves or others to in any public place or thoroughfare. They may be charged with a misdemeanor and sentenced to 1 year in jail and a $500 fine. Lastly, people may be criminalized as a result of a public health order. The penalty for a willful violation of a lawful order issued by a public health official is a misdemeanor, punishable by up to 30 years in jail and a $100 fine. Next slide, please. That's all I have for the specific laws that criminalize people living with HIV. I want to just plug our resource that compiles state laws that are related to HIV criminalization all throughout the United States. We also provide analysis on these laws. I believe the QR code will be shared as well. The next slide also just has our PJP QR code. The PJP team, the Positive Justice Project, houses the HIV criminalization work that we do in working with coalitions such as the one in Oklahoma and other states. So please feel free to stay connected. I'm happy to answer any additional questions, but I'll pass it over to Nathan, who will provide some details on enforcement in Oklahoma specifically.
Thank you, Sean. I had a couple of questions real quick while I know Nathan is going to get set up here at the front. I'm trying to digest everything that you just shared, and I want to make sure that I understand when you were speaking about the criminalization of prostitution, and you mentioned sending a message. Could you maybe expand upon what you mean as far as, I mean, there doesn't even have to be physical contact. Could you maybe help me understand that a little bit more in depth?
Yes, definitely. I'm happy to clarify that. The statute is written as such that the only difference between prostitution and this elevated, quote, aggravated prostitution, I'll call it right now, is that someone is aware of their HIV status. With the way that prostitution is defined in Oklahoma law and probably across the United States, prostitution is either engaging in sex or agreeing to engage in sex, but it's also defined broadly in Oklahoma to include communicating to engage in sex. So the definition includes those behaviors that pose absolutely no risk of transmission, such as communicating online to arrange for sex work, or even existing in an area and communicating with people. We know these behaviors pose absolutely no risk, but the way that the HIV specific sex work enhancement operates, they could be criminalized under the law.
Okay, that is okay. And then as a follow-up to the last, the public exposure, I mean, does that mean, if an individual is in a swimsuit at a public pool, help me understand exactly how that is being applied.
We don't have a ton of insight about how it is being defined or applied because of the lack of clarity within the statute as well as within the case law. We know that it would allow for something like that if you had a certain condition. There is no requirement that you engage in a behavior that actually is likely to transmit or poses a substantial risk. And we know that there's actually no requirement that you actually do end up giving someone another condition. So there's not a lot of allow for something as broad as appearing at a swimming pool. So it's potentially dangerous.
I'm going to ask you one more follow-up. This is Senator Kirt. I know this probably goes without saying, but I feel like I want to make it explicit, which is that if an individual in Oklahoma chooses not to get tested and so doesn't know if they're HIV positive or not, they could not be charged under these statutes, as you've outlined, right?
Yes, and I want to make a slight distinction to that. With the HIV-specific offenses, yes. If a person is not aware of their status, they cannot be prosecuted under this law because it only applies to people who act with knowledge of their positive HIV status. It's a clear disincentive to get tested. We've seen that across the United States, and especially in particular, I want to point to specific research that just came out of California, where we saw that reform of their HIV-specific statute led to an increase in testing because no longer were they penalizing people who were aware of their status. And in Oklahoma, we see that it's specific, or it's clear that only people who are aware of their status would be criminalized under these HIV specific offenses, as well as under the communicable disease exposure statute. I will point out that I'm not familiar with the contagious disease statute. I don't think that it criminalizes people who are aware of their contagious disease, but definitely for the HIV specific offenses, only people who are aware of their status would be criminalized.
Thank you so much, Sean. This is very insightful, and so we appreciate you giving us a deeper understanding of what I counted as 4 enhancements that we currently have on the books. So with that, we'll transition into Nathan. Thank you so much for joining us here in person. He's going to be presenting on the Williams Institute data on Oklahoma.
Thank you. And first, I want to say thank you to both senators for being here today, for convening us all, and for showing an interest in this topic. As you can see on the first slide, my name is Nathan Cisneros. I'm the HIV Criminalization Project Director at the Williams Institute. We're a research center at UCLA's School of Law. And if we go to the next slide, you can see a little bit about our mission statement. Really, the Williams Institute was founded to provide high-quality, nonpartisan, independent, data-driven, policy-relevant research, and to get that research into the hands of policymakers, the legal community, and stakeholders. The idea is to let facts and data, instead of myth and stereotype, inform policymaking and lawmaking, not just for around sexual orientation and gender identity, which is what the Williams Institute is most known for, but also as it relates to HIV criminalization. And you heard from my colleague Sean, HIV criminalization is also a phenomenon in California. HIV criminalization is not a red state or a blue state issue. It's not a big state or a small state issue. People living with HIV can be criminalized because of their HIV status across the United States. So the Williams Institute has for about 10 years now been looking at the enforcement of these HIV criminal laws. And you can see on this slide here, it's actually slightly out of date now. We've added 2 dots in Indiana, including California, where I am, but really spanning coast to coast, trying to understand the who and how of HIV criminalization. If you've worked with criminal legal system data before, you know it can be a challenge to access the data, to understand it. Every state is different as well. And so the data availability are different in each state, but we try our best to try to paint a picture given the data that we have. So here's where I'd like to go. I'd like to talk about those 2 HIV-specific criminal laws in Oklahoma, that exposure law and the sex worker prostitution law. My colleague didn't mention it, but that HIV exposure law actually goes back to the late 1980s. 1991, the criminal penalties were added, and it hasn't really been changed since. In, I think, the late 1990s, there was a Truth in Sentencing Commission that changed the penalties. They were added back in a couple years later. So really, over 30 years now, this law has been on the books. And of course, there have been tremendous strides in the science and medicine surrounding HIV, both prevention, transmission, and treatment. The data that I'll share with you now come from the Oklahoma State Bureau of Investigation, from their Statistical Analysis Center. I want to call out the State Bureau of Investigation. They worked with us for months to try to get these data. It was challenging for their data infrastructure on the back end. I think this was the first time they were able to successfully field a request like this. We were very happy that we were able to get some data from them. This comes from essentially the criminal background check system. So it has information on arrests, prosecutions, dispositions of those prosecutions, and some sentencing data. I'm going to leave the sentencing data aside. It's the most incomplete. Unfortunately, the data may not be comprehensive. So the figures that I want to present now are really a basement floor. They're the most conservative figures we can provide. The actual levels of enforcement might be much higher, but we're very, very confident about the numbers I'd like to share with you. So let me give you a few takeaways. The first is that enforcement continues. We received data earlier this year, and you'll see it in a couple of slides. We had an arrest from earlier this year on an allegation of an HIV exposure crime. Enforcement is quite concentrated, especially in Oklahoma County, but also in Tulsa. Nevertheless, we see enforcement in rural counties as well. People living with HIV are in every county in Oklahoma, and so enforcement actions can happen in every county. We also see convictions under this intentional HIV exposure statute. Intentionality is quite a high burden. We don't actually see that in many other HIV criminal statutes. Nevertheless, people are being convicted not just for other things that they're pleading to, but that HIV-specific crime. And so we'd be very interested if we were able to get court documents or police affidavits to understand how intentionality is being established. And then I'll go into some racial and gender dynamics at the end. I apologize for the small font, but I'll read it to you verbally. So in our data that we received from the state, we identified a little over 100 people living with HIV in the state who have been criminalized because of their HIV status. As you heard from the first presenters, somewhere on the order of 6,800, I think, people are living with HIV in the state. So the incidence among people living with HIV is quite high. We identified almost 150 individual HIV-specific criminal charges and about 130 separate arrests. The overwhelming majority, surprising actually to us because we often see that sex work statute being heavily enforced, That was not the majority. The majority were these allegations of HIV exposure. And again, the statute doesn't require actual exposure of HIV. It does require intent to transmit. It doesn't require actual transmission, and it can also criminalize behaviors that are not even an HIV transmission route. So again, I'd be curious to understand what's going on with intentionality there. Let me show you some time trends. Again, the font is small, but really it's the overall effect that I want to emphasize here. Blue is for criminal exposure. Yellow is for sex work. These are individual charges. If I did it by arrests, it would look very similar. And what I want to point out is that this is not a problem that's gone away with the late 1990s, right? If you were to take the first few years for which we have complete data, the last few years for which we have complete data, you'd be hard-pressed to tell which one was in the early 1990s and which one was in the 2020s. So we see continued enforcement today. You know, there are ebbs and flows, as there are with most things in the criminal legal system. But as I say, even this year, people are being criminalized because of their HIV status. So I want to emphasize again, this is a problem that didn't go away with the ebbing of the HIV/AIDS epidemic in the United States. Let's look at geographic enforcement, and you can see right in the center of Oklahoma, of course, where we are right now, Oklahoma County. These are arrest cycles that began with an HIV-specific arrest. Those charges could also be added later on. We're focusing right now just at that arrest phase. And what you see is 45 out of 114 arrests were in Oklahoma County. Here you can see Tulsa as well, off to the upper right a little bit, and of course the county directly to the south of us. If we look at law enforcement agencies, so the originating agency for those arrests, so getting a little bit more granular, you see Oklahoma PD and Tulsa PD combined actually account for about 50% of all HIV related arrest cycles. I want to highlight as well the Lexington Assessment and Reception Center. That's a DOC facility. If you have contacts in the Department of Corrections, we saw this in a few different counties, the DOC facility, sometimes the jail possibly as well, but those are probably getting folded into the sheriff's departments. We'd love to know what's happening in the Department of Corrections. If somebody can get us granular data on that, we'd love to analyze it and understand how, especially that it's all the exposure offense is being understood and enforced in DOC facilities. So who's being criminalized? What are the pathways? We saw the youngest person criminalized, 19 years old, the oldest, 65 years old. Median and mean actually were right in the middle at about 35 years old. Of course, there were more HIV arrest cycles than there were people criminalized. That means some people were arrested more than once, but the overwhelming majority, 80%, were arrested only once for an HIV-related allegation. So really, the modal story is somebody having a single contact with the criminal legal system because of their HIV status. Unfortunately, about 19%, almost 1 in 5 people, their only contact with the criminal legal system was because of an HIV-related allegation. So when we went to the state of Oklahoma, we asked for all arrest cycles before and after that HIV-specific arrest cycle as well. And what we saw was, nearly 1 in 5, they came into contact with the criminal legal system because of that HIV-related allegation. And we also see that, people can be arrested. Their HIV, for non-HIV specific offenses, their HIV status is learned, and then an HIV specific enhancement is added later on. For example, a person is arrested for sex work, they learn of their HIV status, it's bumped up, or resisting arrest. There was maybe spitting on a law enforcement officer. Spitting is not an HIV transmission route. Nevertheless, they learn their HIV status, and an enhancement is added, or that exposure is added. I want to walk through some demographics now, and then I'll close. And again, it's a little bit difficult to see. On the blue bar, about 80% of people living with HIV in the state are men. That's that yellow bar. And then we can look at the arrest phase, prosecution phase, and conviction phase. What share of people were men? And what you can see is that relative to that blue bar, to the state population, men are overrepresented in HIV-related arrests, prosecutions, and convictions. Conversely, women are underrepresented as a share of the population. Although if you were to compare it to people living with HIV, it's roughly proportional. What about race ethnicity? You see that white people actually are slightly underrepresented as a share of people living with HIV. That is, that yellow bar on the far left is smaller than the gray, black, and red bars. Conversely, Black people, whether it's a share of the state population or share of people living with HIV, are overrepresented in arrests, prosecutions, and convictions. That is, the blue and yellow bars are both less than the gray, black, and red bars. Other race ethnicity, you can see dramatically underrepresented in arrests, prosecutions, and final dispositions. That's not so surprising to us. We often see in criminal legal system data, although I was slightly surprised in Oklahoma, it's often literally black and white. That is, if you're not black, you're coded as white. My assumption is that in Oklahoma, at least for Native Americans, people are probably better at coding that. Nevertheless, what we're really seeing is just black and white people are being arrested, prosecuted, and convicted. We can break it out into smaller demographic groups. And what you see is actually both white men and black men are overrepresented in HIV criminalization. Again, this is surprising to us. I think it's because of the under-enforcement. I don't want to say under-enforcement. The lower degree of enforcement of that sex worker statute means that women in general are not being overrepresented the way that we have seen in other states. Nevertheless, sometimes dramatically so, especially black men, although a larger share of people living with HIV in the state, I think it's something like 7% maybe of the state's population are black men, and you can see well over 20% of arrests, prosecutions, and final dispositions are to black men specifically. And I'll close here. There's a URL. I'm happy to answer questions generally about HIV criminalization enforcement across the United States or specifically here in Oklahoma.
Thank you so much. This is very enlightening.
Oh, and I apologize. And our intent is to have a report published and publicly available in the first quarter of 2025, so during the legislative session.
Thank you so much. This is very helpful. Will you tell me how does OSBI have any indication if individuals are trans who are listed in the data, and is there any way to know how they're being recorded?
Yeah, it's a great question, especially the Williams Institute. We don't do any advocacy except for on sexual orientation and gender identity data collection. No state law enforcement agency that we know of routinely collects this information. We simply can't see gender identity or sexual orientation in the data. We know from qualitative research that sexual and gender minorities are more likely to be criminalized because of their HIV status, but we simply don't have data to say that.
Thank you for that. So one concern that was brought up when we filed the modernization bill last year was specifically around domestic violence. And there was a vocal opponent to the bill who very much cited that this criminalization is important for convicting in domestic violence situations. Did you see that in the data? Is that anything that's come up in terms of a concern?
We have concurrent charges at arrest and at prosecution. Things that would indicate domestic violence were not particularly frequent. It was more often resisting arrest, sometimes assault. There were occasionally sexual violence crimes as well, things like rape. We can't tell whether that happened in a domestic violence context or not, but it wasn't those things that would indicate, those charges that would indicate domestic violence weren't terribly frequent. I will note that we've heard from advocates from both sides of the coin that people living with HIV in potentially abusive relationships as well might be afraid that their HIV status could be weaponized in contact with police.
Thank you so much for presenting this. I look forward to the full report in the first quarter of next year. Obviously, your Senate Sys team is obsessed with data. So anytime we're able to really drill down into the nuts and bolts, this is really helping fuel our call to action and our urgency behind this issue. So thank you so much for your thoroughness in conducting the research. Next, we're going to hear from the Oklahoma City County Health Department. We're joined by Sarah Rains.
Hi, can everybody hear me?
Yes, thank you so much for joining us.
All right. Hi. So I do want to clarify that my role with the City County Health Department is an education role, and I'm going to be getting more into history and context today. So that's a little bit separate from my role with the health department. But I do work in public health, and I'm coming at this with a public health lens and a public health background. So what I am hopefully going to give everybody a little bit of a better understanding of today is the history behind our exposure statute that we just heard about, which is the statute that we see more of our arrests with, how we got to that, what was going on at the time, and hopefully that context can give everybody a little bit of a better understanding of how we got here. So starting off with some of the history, Oklahoma had its very first reported HIV diagnosis in 1983. And then we had our first serious attempt to pass a criminalization law in 1987. So that's kind of, it took a while for us to get to that point. But in 1987, Representative Least introduced a bill, House Bill 1223, that was specifically targeting sex workers who had HIV. What this law would have done would have made it so that people who had HIV, who were arrested on prostitution or solicitation charges, they would then be able to charge with an additional felony for attempted HIV transmission, essentially. Now, something that is important to understand is that Rep. Least wrote this bill and introduced it solely because of a rumor. There was a police officer in Oklahoma City who heard a rumor, who took the rumor to the Oklahoman, which is one of our big state papers. And the rumor was that there was some sex worker in Oklahoma City who had HIV and was continuing to see clients. This was very sensationalized in the little coverage that it got, but it was so sensationalized that a House rep took it seriously enough to write a piece of legislation about it. This rumor was investigated by the State Department of Health, and it was found to be completely false, but that did not change the course of this legislation getting through the House, through the Senate, and landing on the governor's desk. The governor at the time, Henry Bellman, he vetoed this bill. But I think it is still telling when we see that something that was based in a rumor that was false still made it that far in our legislative process in 1987. And I think it also helps maybe demonstrate a little bit how much fear and misinformation prevailed in our public understanding of HIV, if legislators were able to kind of fall for something like that. So starting off not on a great foot with legislation, the following year, 1988, Oklahoma did pass its first criminal law regarding HIV. And this is what turned into the statute that we have today. So this was House Bill 1798. It was introduced by Representative Vicki Miles LaGrange, and this had nothing to do with sex workers, and it actually didn't target HIV transmission really at all. That was not the main focus of the bill. The main focus of this bill was actually to expand patient privacy protections for people who were living with HIV. And this was a really big problem in 1988 and before that, because the broader patient privacy protections that we have today, like HIPAA, did not exist in the 80s. And so what was happening in Oklahoma and elsewhere in the United States is that people were getting diagnosed with HIV, Their records were not kept super confidential, and they didn't have great protections for that status outside of medical privacy either. So people were getting dropped from their health insurance, dropped from their life insurance, evicted from housing, fired from jobs, refused medical care. So the consequences of not having somebody's medical records in regards to their HIV status protected, those were some really serious and far-reaching consequences. And so not only did advocates in Oklahoma City and the rest of the state want to prevent that from continuing to happen, but they also wanted to stop this from deterring other people from getting tested for HIV, because that was a huge problem. People saw this discrimination, they feared it, and that was one of the things that was keeping people from getting tested. So that is why this bill, House Bill 1798, was introduced. It was focused on patient privacy protections, and it had a lot of support because of that focus. People who were living with HIV supported this bill. People who were working in HIV supported this bill. Public health advocates supported this bill. And the coverage that it got in the Oklahoman and also in the gay publication in the state, the Gaily, was very, very positive. Because patient privacy protections were seen as a good thing, right? And they were seen as a very necessary thing. So what this bill said, the text at the time was that this would require strict confidentiality of medical records of those testing positive for HIV, and it would make it a crime to release information from people's health records. Okay, so that was what people focused on with this bill. It turns out that there was also a little additional piece that was slipped into House Bill 1798 that said that it would be unlawful to engage in any activity with intent to infect any other person with the human immunodeficiency virus. So this was a small piece of House Bill 1798. It was not the main focus of the bill, and it was not what the people who supported this bill, that's not what they were supporting. All right. When it was covered in the paper, this part of the bill was not mentioned in any news article that I could find in our state papers. So it didn't seem to be something that a lot of the public was super aware of in general. Even when the bill was signed by the governor, it was signed, the coverage was talking about how it was about protecting people with HIV and their medical privacy. But this is how Oklahoma ended up passing its first HIV criminalization law. All right, so again, it was supported not because there was some great need for criminalization law in Oklahoma or in Oklahoma City either, not because there was a wide support for that type of policy, but because people were focused on the medical privacy protections, right? So this bill passed because it was slipped into another topic entirely that did have wide support. All right, and something else that I think really helps reaffirm the fact that we didn't pass a criminalization law initially because there was a huge need for it, is the fact that this bill was not put to use for another 2 years. But in 1990, the Tulsa County District Attorney's Office decided to test out this law to see how it would work in a criminal case. Because it was so vague, a reminder of what the original bill text said is that it was just unlawful to engage in any activity with intent to infect another person. Because it was so vague, a lot of people didn't think that it would be able to be enforced, and some people thought that it might even be unconstitutional. But there was in Tulsa in 1990 a woman who had previously been convicted on prostitution charges, who was living with HIV, who was arrested for soliciting an undercover cop. And the Tulsa County District Attorney's Office decided that they were going to use this as a test case to see if this law could be used successfully to prosecute somebody. So in the press coverage of this case, the Tulsa County District Attorney said that one of the reasons for doing this was to keep other people from spreading it. So one of the reasons why they were trying out this test case, why they were using it to prosecute this woman, was to try to deter other people with HIV from continuing to have sex. So I think what we can get from this is that this case was not really about this woman's behavior, but it was really about making a public example out of her. And based off of how this law has been used since, we know that trying to make public examples out of people doesn't really deter other people's behavior. And that's not a super effective prevention tool, right? Because here we are in 2024 and Oklahoma very much still has an HIV epidemic, right? This law didn't change that or curb it in any way. So that was the angle here, to make a public example out of this woman, to try to deter other people's behavior, assuming that people were paying enough attention to the news to even find out that this happened. And this case was not covered very much at all. I think there were 3 articles in the entire year of 1990 that addressed this case. But this woman did end up getting convicted and sentenced to, I believe, 3 years in prison from this. So that was the first time that this was used in 1990. And then because it was so vague, because the statute was so broad, the legislature clarified it in 1990 to specify what those activities with intent to spread HIV were. And that is what we heard earlier from Sean and Nathan. That's what our statute looks like today. So that's how we got here, okay? And another thing that I want everybody to understand is that right before this law existed, before 1988, and before it was first used in 1990, obviously Oklahoma had an HIV epidemic, right? Our first case was diagnosed in 1983. So we have 5-7 years passing before any of this is ever used. And what I want everybody to know is that there were already other ways that the state had to handle sexual behavior from people living with HIV that were not involving criminal law. Specifically, the state had determined that the people who were appropriate to address this topic was public health officials. There was already public health statute back from other epidemics like tuberculosis on how to handle people who had infectious diseases. And that statute was used before we ever had a criminal law. 2 examples of how this was used is that in 1986, there was a 24-year-old man in Oklahoma City named Anthony Marks who shared on a public HIV hotline that he had recently specifically been diagnosed with AIDS and that he was continuing to have sex with other people. Now, what I want to point out is this hotline was run by volunteers in the Gay Community Center in Oklahoma City. So that was one important resource, but the majority of the HIV-related resources in 1986 were volunteer run out of the gay community in Oklahoma City. They were not provided by the state. The state was not doing a lot to assist people with HIV in 1986. So I think that is something else that needs to be pointed out. A lot of things were left to volunteers. But anyways, Anthony Marks calls his hotline and he lets the volunteer know that he's recently been diagnosed with AIDS. He is still having sex with other people. He's been given 15 weeks to live. He was in a lot of distress. He was really angry. He was despondent, and he was seeking help. The hotline volunteer didn't really know how to handle this, but what he did not do is call the police about it, because in 1986, that was not really the framework that people had for this kind of thing, because this was before we had a criminal statute. Instead, the hotline volunteer reported this to the State Department of Health. The State Department of Health investigated and eventually determined that Anthony Marks was mentally unwell, and they used public health statute to, through a civil proceeding, to commit him involuntarily to a psychiatric facility for treatment. After about a month in this facility, it was determined that Anthony Marks had been successfully able to change his attitude and his behaviors, and he was released back into the public. And that is where he spent the rest of his life, right? Not in prison, but in public, right? He did end up living a little bit longer than 15 weeks. He lived for a little bit around a year after that. But the point with this is that this was a strategy that looked very, very different than using criminal law to incarcerate somebody because of their behavior. Right? The strategy did not focus on punishing him. The strategy did not focus on making an example out of him to try to deter other people from similar behavior. It focused on working with the actual individual to change their behavior. And it was effective, right? Now, I don't want to say that committing people involuntarily is the solution that we should be looking at instead. That's a whole separate can of worms. It has its whole separate problems. But I want everybody here to understand that there were other ways to handle this before criminal laws that the state deemed effective to carry out what it wanted, right? And this happened again the year later in 1987. There was a man in Oklahoma City. He was living with HIV. He was still having sex with other people. Somebody reported it to the health department. And The health department intervened. They talked with him. He changed his behavior, and that was that. It didn't even end up needing to be escalated further, like with our previous example. And when talking to the Oklahoman, the press about this, the State Department of Health's attorney at the time said that, right, the health department first and foremost tries to get somebody to modify inappropriate behavior. And if that doesn't work, then we can escalate further to using public health statute to obtain a quarantine, to commit somebody, etc. And then this happened a couple of times after that. It was in the press a few more times of the health department using the strategy of intervening in people's sexual behavior with education and behavioral counseling. And it was just fine, right? So it's not like this was a strategy that wasn't working, that required criminal law. This was something that was being utilized effectively. So, and I also want to stress, right, that the reason why the health department was intervening in people's behaviors on multiple occasions was not because people with HIV were being reckless or irresponsible or anything like that. But in the 80s, really specifically, it was a very unprecedented time where we did not understand HIV very well at all, which is kind of what we heard a little bit from with Hope earlier. But in 1988, right, when we had this law passed in 1987 and 1986 with these examples, we still were not totally certain who could transmit HIV and who couldn't. We knew that people could take an antibody test and they could get a positive antibody result, but we still hadn't totally nailed down what that meant. We thought it meant that someone had been exposed to the virus. We didn't understand that a positive test means that somebody does have the virus. That was not super clear at this time. We did not really understand how HIV and AIDS were related. We weren't totally sure what transmission routes were real. And of course, condoms were just starting to be affirmed in the biomedical sphere as effective HIV prevention tools. So there was a lot that we did not know and that we did not understand. And on top of that, at this time, HIV was still considered to be an almost certain death sentence. In 1988, we were almost a decade away from effective treatment. Right. But even with all of this unknown, even with all of this that we were completely in the dark about, still, criminal law, that was not the policy that was being lobbied for. It was not being advocated for. It still was not widely supported by the public. It was not being advocated for by public health professionals. It was not being asked for by the people who were working in HIV, right? Because what already existed was working just fine. And it does seem that the few people who did feel like this type of criminal law intervention was appropriate, the reason why they felt that way was because of this lack of information and this lack of medication. But obviously that's very different today, right? We know how HIV is transmitted. We have very effective prevention medications. We understand how this works. And we know that HIV is not a death sentence, right? And we also understand that using laws like this to try to deter other people's behavior is not really an effective prevention strategy. Public health focuses a lot on working with behavior change, and working with people on an individual basis is gonna be a little bit more effective than hoping that people are paying attention to the news to see what's happening to other people. So that was kind of a lot. We kind of flew through that, but I think it's important to have these different pieces of historical context so that we can understand that the intent that we might give our criminal statute today is not necessarily the intent with which it was written. Right? It kind of happened a little bit by accident. And I think that this context can help people further evaluate whether laws like this are helpful and worthwhile endeavors, or if there are maybe other avenues that could be explored for handling this that might make more sense. And seeing that, yes, that there is historical precedent for handling things like this outside of criminal law. And Oklahoma did that for years and years and years. So that's all that I have. If there are any questions about any of this, now would be a great time because I do have to hop off of this call afterwards.
Thank you, Sarah. Really appreciate the detail to which you were able to kind of highlight and explain how we got here. I don't think Senator Kirt or I have questions at this time, but I just so appreciate you making yourself available to give us this explainer today. Thank you again for sharing your time with us today. So we're going to transition to our next speakers. Next, we have a presentation basically on what the next steps in a public health context would look like to respond to public health with public health policy and not criminalization. So I'm honored to welcome Vivian Topping with Equality Federation and Nicole McAfee with Freedom Oklahoma. Vivian, thank you for joining us today, and I hope that your 24-hour trip in Oklahoma is just delightful. This weather is unexpected, but also welcomed in the heated context that we've had in the last several weeks. So thank you, Vivian.
There we go. Sorry about that. So again, thank you, Freedom Oklahoma, for bringing me here. Happy to be here. My name is Vivian Topping. I'm the Director of Advocacy and Civic Engagement at the Equality Federation. Equality Federation is an advocacy accelerator rooted in social justice, building power in our network of state-based lesbian, gay, bisexual, transgender, and queer or LGBTQ+ advocacy organizations. We believe that the greatest opportunities for victories to improve the lives of LGBTQ+ people are in the states. We partner with 49 state organizations like Freedom Oklahoma in 40 states across the country to drive lasting change. Our state partners form the largest national network advocating for LGBTQ+ equality and liberation. And we use this network model to ensure that advocates pool resources, learn from each other, and develop best practices to avoid redundancy. Our public health program brings LGBTQ+ advocacy power to HIV policy in the states under the leadership of people living with HIV and in consultation with HIV advocacy and service organizations. We work with our state partners to leverage this power to end the criminalization of HIV, to address additional needs of people living with HIV, and advance policies to end the epidemic. They couldn't be here today, but our public health policy department is led by the amazing Michael Elizabeth, someone with over 14 years of lived experience and deep passion for this work, and I'm honored and humbled to be here representing for them today. Equality Federation currently partners with over 10 groups to build their ability to advance HIV-related policies and legislation that is in alignment with the federal ending the HIV epidemic plans in their state. Additionally, we provide general HIV support and trainings to all 49 state partners. Since 2014, at least 16 states have modernized or completely repealed HIV criminalization laws, most recently in states like Kentucky and Tennessee, proving that modernizing HIV laws is a nonpartisan, non-political issue. In partnership with other HIV advocates and people with lived experience, we've had success in providing support to state partners updating their HIV laws. In Nevada with Silver State Equality, in New Jersey with Garden State Equality, in Virginia with Equality Virginia and Echo Virginia, in Illinois with Equality Illinois and the AIDS Foundation of Chicago, and in Georgia with Georgia Equality. There is momentum building to decriminalize and modernize these HIV laws everywhere, particularly in the South. We love working with the folks at Freedom Oklahoma and their local partners who have a deep commitment to improving the quality of life of communities living with HIV. We know HIV is a matter of public health, and after decades since becoming law, there is no evidence that HIV criminalization promotes public health or prevents new HIV transmissions. The current law in Oklahoma states that a person living with HIV can go to prison for 5 years for not disclosing their status before consensual sex, even when they did not intend to harm anyone. There was no risk of harm, and no harm resulted. This is a more severe punishment than for second-degree manslaughter or domestic abuse by strangulation. The money spent to incarcerate people under HIV criminalization laws would be better spent on HIV prevention efforts and supporting the more than 6,000 Oklahomans currently living with HIV. Despite having an HIV-specific criminal statute, Oklahoma was identified as one of 7 states in the U.S. with the highest rural burden of HIV, and HIV diagnosis rates have not dropped despite these criminalization laws. In fact, HIV criminalization may discourage testing, as we've heard already today, and knowledge about an individual's status. There's an increased need for education and prevention, with 21% of newly diagnosed HIV cases in Oklahoma among those identified as late testers, or people who have received an AIDS diagnosis less than 3 months after they first tested positive for HIV. HIV criminalization in Oklahoma perpetuates stigma and discrimination against Oklahomans living with HIV. Criminalization also unfairly targets individuals in marginalized communities, including Black and Brown communities, LGBTQ+ people and sex workers, and puts them at further risk of incarceration and poor health outcomes. HIV-specific laws disproportionately affect these communities that historically are more prone to harmful interactions with the criminal legal system. It is discriminatory and results in unjust prosecutions. And so what would it look like to prioritize public health over criminalization? Having a virus should not be a crime. People living with HIV are part of our families, our communities, our workplaces, and our places of worship. Oklahoma could be a beacon of hope for people living with HIV throughout the South. We could accomplish this by supporting policies that enhance people's quality of life, which includes access to HIV treatment and resources for treatment. As an HIV negative person and a transgender woman who takes advantage of PrEP, I have had access to this kind of support, and it has been life-changing for me to be able to have the right knowledge to educate myself on HIV. This is why I try to work to create a world free of stigma and fear for my loved ones and friends living with HIV. This is a public health solution to a public health problem. The legislature's goal should be creating healthier communities by removing barriers to prevention, testing, and treatment for Oklahomans. Healthcare is the answer, not punishment. Instead of criminalizing people via laws like the STI criminalization bill, Oklahoma needs to prioritize sex education and real public health discussions so we can talk about sexually transmitted infections in ways that are a public health response and not criminalization or focused on moralistic responses. The Centers for Disease Control and Prevention, American Medical Association, National Alliance of State and Territorial AIDS Directors, National Association of County and City Health Officials, U.S. Conference of Mayors, the U.S. Department of Justice, and other organizations have all called for states to repeal or reform their HIV-related criminal laws. And criminalizing STIs is also expensive. Oklahoma already has one of the nation's highest incarceration rates, and the state spends $28,500 annually for every person incarcerated. Compare that to the cost of under $200 to treat many of the STIs that bills like last year's HB 3098 seeks to criminalize. Those resources would be better spent on healthcare, including STI prevention, testing, and treatment. The best focus for our states is to expand access to testing and treatment for HIV and do away with harmful and ineffective punishments. Smart policies and community health investments can help ensure that all of us have the health care we need, no matter who we are or where we live. Happy to take any questions or also hand it off to Nicole.
Thank you so much. I appreciate everything you shared with us, and I appreciate you being here. When you're talking about, you gave the statistic on what it, I believe, is probably to house an individual for a year. Could you repeat that?
I believe it was $28,500.
And then to marry that, I guess, with what costs of prevention might be, could you maybe quantify?
About $200.
Thank you. I appreciate you so much. We'll now welcome Nicole with Freedom Oklahoma to basically put a fine point on a public health approach.
Thank you so much. And thank you to everyone who joined us virtually today as well. As Senator Hicks said, my name is Nicole McAfee. I use they and she pronouns, and I'm the executive director of Freedom Oklahoma, our only statewide dedicated to us LGBTQ+ advocacy organization. I have notes here just to put a few fine points on what so many experts have shared with us today. I want to take us back. I think Sarah made this point especially, but just to the idea that we started efforts to potentially criminalize people living with HIV before we started efforts to educate anyone about HIV or AIDS in a public health context. As our friends from Hope shared earlier, Oklahoma's education statute regarding HIV/AIDS was drafted and approved in 1987 and has not been updated since. We've heard a lot today about how much has changed since 1987. In 2019, we saw a successful legislative effort to try to modernize that statute that ultimately was vetoed by our governor. And I think oftentimes about the context of public health education from folks who are decision makers in enforcing these criminalization policies. When Representative Turner authored a similar bill, and it was heard in the House Criminal Justice and Corrections Committee, mostly by legislators who have a history of work in criminal justice and correction spaces. Questions were really rooted in a lot of misinformation, a lot of old false information and rumors around how HIV is spread. And we heard those questions asked on the record from people who were not only making a decision about the criminalization law, but who also had been charged with enforcing it at different times in their careers. And so oftentimes I think about the number of people going through the criminal punishment system. We saw, conservative estimates from the Williams Institute around impact that at every point, those decision makers are not receiving updated education information about HIV, about potential spread, about potential harm. And oftentimes they're operating on some really outdated information, even if they have had access to that education in the Oklahoma public school system. I think further about the fact that we heard that one of the criminalization statutes that targets HIV specifically was originally authored in 1910. And I think about how much public health approaches have changed since 1910 to 2024. And the idea that we are still using that same approach with regards to targeting folks living with HIV feels really wild to me. And I think it's important to say out loud that we are using really outdated ways to tackle a public health problem through the criminal punishment system that aren't ultimately having anything but further negative effects. We talked about that 1987 public health law, and I want to note that in a 1986 AIDS update from the Gailey, a gay publication in Oklahoma, based in Oklahoma City, that they reported that typically in Oklahoma, people diagnosed with AIDS died in 4.3 months after being diagnosed. At the time, the comparable US average was about 18 months. So we have seen from the beginning a really sort of stagnant approach, often rooted in late testing because of stigma and fear. And as we heard Vivian mention earlier, in the last 5 years, approximately 21% of newly diagnosed HIV cases in Oklahoma were among people identified as late testers. So those who received an AIDS diagnosis less than 3 months after their first positive HIV test. And there's no reason for that to be the case. And we, as long as we have these criminal statutes on the books, are disincentivizing people from accessing testing resources. I want to say, just to put a point on this, I'm someone who grew up in a really small town. I graduated from a public countywide school with 14 people. I have lived in Oklahoma City for a while now, but I have also lived and worked throughout the state in places like Pryor. I have lived in Burnt Cabin out in Cherokee County. And I think when we think about rural burden and harm in particular, I know folks who, in order to access resources like AA groups, would drive 2+ hours away, would travel across state lines because of fear about accessing local resources and stigma related to that. And I think that we only see that so much more so when we are talking about the way that HIV is still stigmatized in a state like Oklahoma. And so I think that we have a responsibility as we do this work to engage in not only the repeal work of modernizing these criminal statutes, in work to try to repair the harm to people who've been criminalized, but also to engage in destigmatization, public education, and support for folks who do the valuable testing and prevention work throughout the state. And with that, I just really want to thank you so much for holding the space for all of us today, and hope that we can continue this conversation.
Thank you so much. I don't think I have any questions because I think we've gotten a talk, but I want to just thank Freedom Oklahoma and thank Nicole for leadership on this issue. I want to thank Representative Turner, who started these conversations in the building. And I think there's certain things we can do in the community without the state legislature taking action, but we know that we're talking about some of the very specific ways that the state has to change the law to make improvements, and is about our approach as a state. Are we going to focus on prevention? Are we going to focus on the very expensive response and hazards to humans across the state from not focusing on prevention? Thank you for the data. Thank you for the science and evidence information that's so valuable. I think I encourage you to consider to continue to speak up to legislators in that way. And if we're not making decisions using the data and information and lived experiences that you know exist and are important, please make sure that your legislators are hearing from you with that information. We will continue to fight to have a shift in our mindset up here around public health and criminalization. And I think you're arming us with very important information we need to move forward. And I think working together that we can make change in this area and others.
Thank you, Senator Kirt. Really, I just want to say thank you. Today's intent for me, or my top goal, was to really carve out space for the voices who have been doing this work and have been carrying that public health approach and carrying that public health response for so many thousands of Oklahomans who are potentially subjected to these consequences just by virtue of leaving their homes every single day. And so I just appreciate the intent and the care that you all have been giving to our neighbors in our communities. And I look forward to a lot of ongoing conversations around this topic in particular. And I think that concludes my formal remarks, but obviously, please feel free to stay around. I appreciate everyone who joined us virtually today, and I'm very grateful that we'll be able to get the broadcast. So thank you all very much.